Testing. Testing 1 2 3. Testing 1 2 3. Checking, checking. Testing. Testing 1 2 3.
Hello, check. Hello, hello. Hello, check. Hello, hello. Hello, check. Hello, hello. Hello, hello. Hello, check. Hello, hello. Hello, hello. Hello, check. Hello, hello. Hello, check. Hello, mic testing check. Hello, hello. Hello, hello. mic testing check. Hello, hello. Hello, check. Hello, hello. Hello, check. Hello, mic testing check. Hello, hello.
So, good afternoon, everyone. Welcome to one more session of today's CME. In today's, actually, basically, it's not more of a CME, it's like a student development program. We have a guest speaker, and the topic of today, as you can see on the screen, it's about stem cell therapy, about critical size of bone defects. We have a eminent speaker, and to introduce today's speaker, I call upon Dr. Nagarjuna. He will introduce the speaker for you people.
Good afternoon, everyone. It is my privilege and honor to introduce today's distinguished speaker for the Faculty and Student Development Program on Stem Cell Therapy for Critical Size Bone Defects. We are delighted to welcome Dr. Uma Devi Kandalam, PhD, a renowned academician, researcher, and mentor in the field of physiology. Dr. Uma Devi Kandalam serves as an associate professor of physiology at Woody Hunt School of Dental Medicine, Texas Tech University, El Paso, USA. Over the years, she has made remarkable contributions to stem cell biology, tissue engineering, and regenerative medicine. Her outstanding work has earned several prestigious honors, including Faculty Scientific Researcher Award by the American Association of Oral and Maxillofacial Surgeons, a prestigious research award from the Osteoscience Foundation for her significant contributions to craniofacial regenerative research, and the Best Researcher Award from the International Society of Computer Scientists, recognizing interdisciplinary excellence and innovation. These awards stand as a testament to her dedication, scientific rigor, and impactful contribution to global research. Dr. Uma Devi has also guided numerous students, received 40 research grants, published 38 papers in reputed scientific journals with a H-index of 16, and presented her work at 70 national and international platforms, inspiring young minds across disciplines. Today, she is here to enlighten us on cutting-edge and rapidly evolving area, stem cell therapy for critical size bone defects, a subject that holds immense promise for the future and regenerative and clinical medicine. She is here for a very short trip and obliges our request to be with us for a short while. Ladies and gentlemen, please join me in warmly welcoming Dr. Uma Devi Kandalam to the stage. The stage is yours.
Thank you very much for your kind introduction. Good afternoon. It is really my honor and I feel elated actually to see all medical students, and in this platform I am actually sharing my research findings. I am really, when I entered into the campus, I saw goddesses Saraswati Devi, I saw a lot of leaders, Mother Teresa. I can imagine how much service you are all doing for the society. I really wonder and also appreciate all your efforts for the service. With that, I just want to introduce, I want to talk about how I got into this field, stem cells therapy field. I had an opportunity. I worked in cancer research. My primary research was in cancer. And then I shifted to cardiovascular. And then I had an opportunity to get into College of Dentistry from Florida, actually, Nova Southeastern University, Florida. And there I worked with a plastic surgeon, pediatric plastic surgeon, and he's very much interested in developing this stem cell therapy and tissue engineering. And what he does was cleft palate repair. He's a surgeon in expert in cleft palate repair. He does use BMP2. A lot of you know about BMP2, and he used to discuss with me. So that is, he used to tell me that this is my long-term goal, stem cell therapy. Why can't we establish this? I said, yes, we start. So from the beginning, I started this stem cell therapeutic research, and I want to share where we are. And I consider myself it is still in baby steps. We have to do a lot more, but I like to share my experience with stem cell therapies. So where can I start the slide? This is my school where I'm working now, Woody Hunt School of Dental Medicine. I'm in Texas and border of Texas, actually, Mexico and Texas. It is El Paso. So where they have lot of cleft palate patients. And as you know, most of these patients, they are culturally, in Mexico also culturally, they are not, they don't want to come to the physician or surgeon to have the conversation and about what is happening. So they don't come immediately to the surgeon. That's the reason cleft palate is most prevalent there, and diagnostic techniques are very meager there. So I thought that, okay, I moved from Florida to Texas, and the same situation there also. So mostly I focus on a cleft palate, but still it is kind of bone regeneration. I'll talk about how we regenerated bone utilizing dental stem cells. So as you can see here, craniofacial bone loss happens by various defects like cancer, or you can see the trauma, fracture, and congenital defects. And these cause the bone defects there, and it is really important to take care of this regeneration of bone. And if you see the cases of cleft palate, it is 1 in 500 globally, and 1 in 700 in the United States and other countries. So it is very important to focus on how we can manage this. As all of you know that it's an integrated approach, right? Speech therapist and orthopedician and plastic surgeons, and also pediatric dentistry and orthodontist. All these people are physicians or medical team should work for the repair of this cleft palate defect. And not only that, and cancer also, it's most prevalent. And what happens is, right now I'm working on another project also, osteonecrosis. And due to cancer, they use, to prevent osteoporosis, they use bisphosphonates, and eventually the bone necrosis is happening because of avascular conditions. And that is one reason bone loss will be there. And if you look at this, bone loss happens, but if it is manageable, we don't need any bone graft. But if it is not manageable, meaning that if it is a critical size defect, how many of you know about this definition, like critical size defect? Critical size defect is a defect that it is a minimal size defect which cannot be healed spontaneously. So we need a bone graft. Beyond this size, definitely we need a bone graft. So that is where we call it as, it's a threshold. So that's where we call it as critical size defect. So when bone graft is necessary, when the critical size defect is there, bone defect is long, bone defects are there we need bone graft. So what kind of bone grafts we use? Usually we use autografts. That is a gold standard, right? Autograft is gold standard. Why we use the autografts? Because highly vascular, bone is highly vascular and easily we can, the blood supply is easily goes through and bone will regenerate immediately. But if you can imagine in a cleft palate baby, how much bone we have to take, and also if you are taking the bone, again you are doing another surgery, right? So bone morbidity is happening. So we really honor autograft, but still we have a lot of limitations with that. And if you take, for example, allograft, it is also good model, but there are like a risk of infections there and immune resistance. So what we thought is, and some xenografts are also there, like bone substitute and other things. And what we thought is, why can't we start a stem cell therapy? It is a viable option, right? So in stem cell therapy, when we are doing any stem cell therapy, especially for bone tissue engineering, we need 3 components. What are those 3 components? As you can see the cells, which are stem cells, and signals, which can recruit the undifferentiated stem cells and differentiate, and they provide the signals. And what is the other one? Extracellular matrix, right? Bone consists of what? Collagen and hydroxyapatite. So extracellular matrix is important. And so that's how any bone regeneration requires cells, signals, which are growth factors in this case, and extracellular matrix, which can give as a framework to the stem cells. So these 3 components are important for tissue engineering. A lot of scientists, they investigate, but only engineers can rebuild. So that's why it is called tissue engineering. And what is actually stem cell? Any cell, if they divide into 2, it's a mitotic division, you will expect 2 similar cells, right? 2 daughter cells. Is it right? In stem cell division, what happens is, it's not like a symmetric division, it is asymmetric. What does it mean is, it has one cell always self-renew. It has the capacity to self-renew, meaning that stem cells, they keep their property. Stem cells have the property of undifferentiated state. So they keep their property as undifferentiated, and other cell will act as a progenitor cells. So what progenitor cell does? It will help in differentiation. So how does it work? I mean, starting is undifferentiated cells, and they develop into progenitor cells, and then they develop into terminally differentiated cells. And as you know, many of you, when we talk about stem cells, we think of embryonic stem cells. We get stem cells from embryo and as a discarded tissue also sometimes. But you can see how it develops. Embryonic fertilized egg, sorry. So embryonic cells starts from fertilized egg, and also it goes into totipotent stem cells and blastula stage, and that's where it becomes a pluripotent state. And embryonic stem cell has a lot of advantages, that whatever cell you want to, whatever lineage you want to, we can make it. But what are the concerns about embryonic stem cells? Some ethical concerns are there, right? So we want to avoid those kind of ethical concerns. So what we scientists came up with in 1950, they started thinking about, some stem cells they were looking at in the bone, but they couldn't name it or they couldn't identify. And in 1970, that's when Friedenstein, he observed the bone marrow. And bone marrow consists of hematopoietic stem cells, and also the stem cells, they are like a stromal cells. He found in a connective tissue some undifferentiated cells, and he found that there are some stromal cells which has the ability to regenerate. And later on, they started digging of more stem cell sources. When Friedenstein started, they thought that it's adult stem cells or postnatal stem cells. Every single differentiated organ will have some undifferentiated cells. So they started calling it as stem cells, but still the naming was given by another scientist. We'll look into that slide. And here, after detecting, they started getting the lot of stem cell sources they identified. So for example, it is like a Watson jelly, umbilical cord, and you can see lot of different tissues. They also have these stem cells. They are called adult stem cells or postnatal, or one word, it is called mesenchymal stem cells. So he's the one, Arnold Kaplan, he has derived this term as mesenchymal stem cells or mesenchymal stromal cells. Why we have given that name? Because it is coming from a mesenchyme, like mesoderm origin and connective tissue. That's where we started calling it as mesenchymal stem cells. They are nothing but postnatal stem cells. And after, the research has been developed in stem cell field, and the International Society of Cellular Therapy, this is most important to know that they have given some guidelines. It is still, it's a gold standard even now. They have given guidelines. What do you call as a mesenchymal stem cells? What are the properties? As we discussed, embryonic stem cells have ability to differentiate into any organ, whereas these mesenchymal stem cells, what they have given the guidelines are, they have to have the property to adhere to a plastic surface. Why they have said that? Because hematopoietic stem cells, they can be cultured in a cell suspension. But whereas these mesenchymal stem cells, they can adhere to a plastic surface. So that is one property we need to demonstrate. whether it is adhering to plastic surface. And the next property to be considered as mesenchymal stem cells, they have to express some surface proteins. So what are those surface protein or surface markers? So they are, these are all cluster differentiation markers. Sorry. So they are CD90 and CD73, CD105, that is the endoglin. These are all positive to mesenchymal stem cells. They have to be positive. That is when we consider it as a mesenchymal stem cell. That's one property we have to have. And some markers, they need to show less than 0.2%, which is almost negative. So those are markers are CD34, CD31, that is called PECAM, and CD14. These are the specific markers for hematopoietic stem cells. So we want to separate the hematopoietic stem cells and mesenchymal stem cells. They show negative to these cells because everything is coming from bone marrow, right? So we need to separate which are mesenchymal stromal cells and mesenchymal stem cells. And they have to have at least three lineage differentiations. They have to give rise to three lineages. What are those lineages? We will see here. These lineages are at least cartilage, bone, and adipocytes or fat. So these lineages, they have to exhibit. All these three characters they have to follow. This is the guideline. Then only we can consider them as mesenchymal stem cell sources. How do we differentiate? As you can see here, we have these mesenchymal stem cells. They are going into neuron also. That's extra. But according to guidelines, they can go to muscle cells, insulin and FGF. They're different chemicals. It all culture media with these chemicals are important to differentiate. And also some signals, growth factors, as I said. We will look into that. And these growth factors, if you can see, for chondrocytes, you can see the dexamethasone and TGF-beta. These are the growth factors they use, and high glucose. If you change some composition, it will get into osteoblasts, ascorbic acid, beta-glycerophosphate, and all these things. So I'm just giving you example that how we can differentiate. Culture media is important. So as we have seen, lot of stem cell sources are there. I started my research with umbilical cord stem cells. We got the umbilical cord from the company. Actually, I started with getting from the company, and later on we wrote institutional review board IRB protocols, and then we got the tissue. But what I found is it's very good source, stem cell source. It's not, it's very good source, and we got lot of cells, but still it can be obtained from discarded tissue. That's one stem cell source. You can use it as a medical professionist. And what I thought was, how can we get an easy source of stem cells? How can we obtain? So my focus, as I said, as in cleft palate repair model, and I thought that even the baby tooth, before it arises, why can't we get some stem cells from the gum? So I thought, okay, we'll try this source. So, and I looked at literature, and lot of advantages we found with gum-derived stem cells, which is gingiva-derived stem cells. So what are the advantages? Why I have chosen this gingival derived stem cells? The first thing is it bone marrow stem cells is ideal for bone regeneration, obviously, but gingival bone marrow stem cells after 10 generations, the potency is reduced, and we cannot get millions of cells. Whereas gingival stem cells is highly proliferative. So you can get in 2 mm tissue, from 2 mm tissue you can get millions of cells. That is one advantage. And second advantage is it is equally potential as bone marrow stem cells as in directing the osteoblasts, in differentiating the osteoblasts. That's one advantage we found. And another advantage is very important is immunomodulation. Gingiva, the tissue, it has anti-inflammatory, and also it has wound healing capacity. So that's very important, right? As a medical professionalist, you will expect like a scar tissue or scar formation. Gingiva, using gingival stem cells, we don't get that much scar, actually, reduced one. And another important thing, as I said, I have been working with craniofacial bone regeneration. These cells are coming from neural crest, which I think you might know about neural crest and their functions. These neural crest derived stem cells are responsible for whole craniofacial region formation. So that is what gingival stem cells have 90% of these neural crest derived stem cells. That is where I was very fascinated. Right now we are trying to isolate the homogeneous population from neural crest. That's one of our projects. And that really attracted me. And we started working on these gingival stem cells. And as I said, it is major histocompatibility, MHC, like HLR, HLA-DR is negative here. So we can use these stem cell sources as allogenically, not only autologous, allogenic source. So this is just stepwise manner we went ahead, and we have done that. We isolated gingival mesenchymal stem cells from the tissue, primary tissue, gingiva tissue, and we characterized it, and then we applied it, so in rat models. So when we plate the cells, we have done enzymatic digestion, and we have done some explant cultures, and we plated these stem cells. If you can see that, it looked like embryonic stem cells, and we looked into the literature. A lot of embryonic stem cell markers are also exhibited by these gingival stem cells. And when it becomes confluent, you can see millions of cells there. Yeah. And the next thing what we have done is, as I said, international cellular therapy standards guidelines, we wanted to see the surface markers. They're all proteins, surface proteins, on the membrane proteins. And as I said, we looked at all the markers, and CD73 positive, CD90 positive, and CD105 and CD166. These are all mesenchymal stem cell markers, positive markers. And as we expected, so these are CD45, CD34, and CD14. These HLA-DR, these markers are negative, showing that they are not hematopoietic stem cells, and also they are not any T cells or immune cells. So these are mesenchymal stem cells. As a next step, what we have done is we showed that multi-lineage potential of these stem cells. How did we do? We differentiated, as I showed in one of my slides. So we have given different chemicals along with the culture medium, and we have grown that. And after 28 days, we see in osteogenic differentiation, you can see the orange color. It's a staining agent, alizarin red staining. What it does is I have given the cells without any treatment. It is just stem cells for 28 days, and after 28 days, this is differentiated stem cell. This group is differentiated group, and you can see this mineral deposition. It has all the mineral deposit, calcium deposition is formed in this slide. So that's the indication. The orange color is representing that mineral deposition here. You can see the cells become minerals. And this is indication of bone formation in vitro in the lab conditions. And here you can see the cartilage. So chondrocyte formation here. Just stem cells, we guided them with growth factors and different agents, and we differentiated them into chondrocytes. And here you can see the lipid globules and adipocytes. We differentiated them into adipocytes. And what we have done furthermore, we wanted to look at the gene expressions, the marker gene expressions, which are important for bone formation, which is osteocalcin. My research goes with bone, so I was interested in looking at more deeper into the bone formation. So we did a bone forming marker. If you can see that, just this group is OM plus, CM is a growth medium, and osteocalcin is improved here. And also here one of the, this is with PCR, and one of these markers are osteopontin is also bone specific marker. It also enhanced. We did some Western blottings, and we wanted to show in flow cytometry data also how the cells are differentiated. We have done that, and lot of markers CD 166. These markers has shifted from negative to positive. These some of the markers. So there are bone specific markers. These are all bone specific markers. So the first thing with this, we have characterized our stem cells, and I do this in a routine method. Every single batch of gingiva tissue we will get it, and we characterize it, and batch wise we will preserve it. We will just cryo preserve it and for future experiments. So now I wanted to find out, as I said, tissue culture, tissue engineering requires cells, signals, and scaffolds. So I wanted to look at the growth factor or signal which can differentiate them quickly. What we have done with normal osteogenic medium, then we wanted to enhance the differentiation. So we looked at the growth factor, which is very popular, which oral and maxillofacial surgeons routinely they use, that is called BMP2, bone morphogenetic protein. So bone morphogenetic protein is also a growth factor, and it is very much important for recruiting the stem, recruiting the differentiation, or recruiting the cells towards differentiation and proliferation also. And what we have done is I took the recombinant BMP2, and usually in clinics I don't know here in India, but the Medtronic company, they give a package. It is called infused bone graft. They use collagen sponge and they use a BMP2 solution. So there is no standardization, but yet they give like 1.5 ml of BMP2 and the certain amount of collagen sponge. The oral and maxillofacial surgeons, if there is any alveolar defect, they put this BMP2 and they soak it in collagen sponge and they will use it as a bone graft, and it works wonders. It is very important. I mean, it enhances the bone regeneration, but yet it is not forming bone in the orthopedic area, but ectopic area also it is coming. And the patients, they used to come back with the allergic and inflammatory reaction, inflammation, lot of inflammation. So what we thought was, it's good idea, because BMP2 we have to honor because it's very good differentiating agent, but yet we wanted to reduce the quantity of BMP2. So we have done a lot of, I did not show many of my slides here. We have done a lot of experiments standardizing BMP2 and the concentrations, and mineralization is the hallmark for bone regeneration. We have done some mineralization experiments. We found that 100 nanograms of BMP2 is enough to induce the bone formation, but we use more here. Supraphysiological doses we use, and as a result, even BMP2, excess use of BMP2 causes cancer. So that's why we standardized, and with that we have done stem cell standardization, and we have done the growth factor standardization. Now we were looking for a material, extracellular matrix material, which can hold the stem cells when we graft in the defect. So that's when we started looking at that, and this is kind of a framework what we have. Scaffold is an extracellular matrix, and it is very important to hold the stem cells, and especially in bone tissue engineering, extracellular matrix is important. So in bone, the collagen is extracellular matrix, but when we are obtaining the synthetic scaffolds, we need to look at a lot of parameters, because it has to be, the stem cells have to go around, migrate around, and stem cells have to proliferate when we are putting the cells into the defect. So that's why we checked a lot of scaffold materials. There are a lot of natural materials like ceramic and other natural materials. And here I have to mention this point, biocompatibility is important. When we are testing any material, we need to do biocompatible studies. My lab has done a lot of testing of these materials, and we have done biocompatible studies. And next one, we found a lot of natural scaffolds we observed, and also synthetic scaffolds also. Finally, I went ahead and I used one material which is called self-assembling material, a scaffold material, which is a hydrogel. What it does is, it is in the liquid form. The hydrogel is in liquid form. When we put the stem cells inside, and when it goes to physiological condition like 37 degrees and pH is 7.2, then it becomes like a solid material. So that is when we observed this self-assembling scaffold material was a very good material to work with our stem cells. So I use this material called Puramatrix, and it is injectable. It is very much injectable and easy to handle that. And we identified this material would be better for us. And then we went ahead and I'm not going into details of this, but this is a study. We did the biocompatibility studies. We wanted to test the scaffold in the lab conditions, whether their cells are alive or not. All these cells are alive in that material. And then we did some scanning electron microscope studies also to look at the surface structures. And we did that, and again, the ultimate goal is mineralization. We did some mineralization experiments that is also successful with this scaffold material. And then we started, like, we established everything in the lab conditions. We established the material, stem cells and growth factors and scaffold material. And now we are ready to test it in animal models. That is when we started creating the animal models. We have created the alveolar cleft model. So I think a lot of you know about this. Mostly alveolar cleft requires bone graft. So that's why we have chosen this alveolar cleft model. And in rats, we have done that. It's a big project. It's not easy project. We have to write the protocols and come up with models. And this is, the instrument is MicroCT. With the help of MicroCT, we have shown these pictures. Like this is a 3D picture where the alveolar defect you can see. And these are the defects, and we have made a critical size defect. So it doesn't heal by itself. Spontaneous healing doesn't happen, but we have to have a bone graft. So we already have the stem cell based bone graft. So now all we need to do is we have to test it. If you look at this, it's a 2D of MicroCT picture. We made the defect. This is no intervention, no surgical treatment in this group. After 4 weeks also, you can see that the defect has not healed. And second group is just the material, scaffold material, it did not heal. And this is BMP2 group, which some healing is happening, and just stem cells and scaffold, some healing is happening. But at 4 weeks, you can see bone is like a defect is little bit closing with all these stem cells, scaffolds, and growth factor. This is 8 weeks. 8 weeks also you don't see any healing. I mean, light healing is there, but not defect is not closed. And just BMP2 group also doesn't work very well, but stem cell group worked. And if you look at this picture, after 8 weeks of such surgery, completely almost 90% healing happened with stem cells and growth factors, and also this material. So that is our first project. We have successfully regenerated bone. I think the time is up. And we showed histologically, we showed that it is just defect without any intervention. Some fibroblast and connective tissue was there, and you can see the bone is lying there. The bone was regenerating here with the stem cell group. So we have shown, this is the summary. First we have established some stem cells, and we have shown that it is potential to differentiate into osteogenic cells. And we have made the critical size defect, and we used these stem cells. in a rat model, but these gingival stem cells can be utilized as autologous or allogenic stem cells also. So we have another project also on focusing on vascularization, but I just show our defect model. This is craniofacial defect, calvarial defect model. We have done that, and now in this project we have differentiated the stem cells into endothelial cells and also osteogenic cells. Both the stem cells we have recruited. You can see from here, it is just that one material we put that DBM, which is demineralized bone matrix, and you can see the difference between the stem cell group and just material group and growth factors group. So I mean, because we have time constraint, so I'm stopping here. And this is our lab crew, and I have a lot of collaborators, and all these foundation grants what I received, they wanted to see applied aspects. How do you show us the regeneration? So I did that, and now I'm starting some mechanistic studies also, like signaling pathways. What is the mechanism? What is happening there? Yeah. This is for students. We hurry to do some things, but slow in mind, but have patience, everything can be achieved. Thank you so much. Any questions? It is little extensive. I hope I made it simple, I don't know, but.
Good afternoon, madam.
Yeah.
Excellent presentation. Your journey was literally inspirational. So what I had in my mind, so maybe it can match what has been, what you have done. So I'm a microbiologist by profession. So we have back of our mind, we usually think of cell lines for virology research. So we also think about or microorganisms which are very difficult to cultivate.
Uh-huh.
So till now, many of the we think about usually my teachers used to teachers used to joke about, if you are able to discover a media for lepra bacilli, you will be able to you will get a Nobel Prize. Okay, so that way it has been always been in the back of my mind. So the thing is, can stem cells derived from appropriate animal host? For example, 9-branded armadillo is the most appropriate host known till now for growth and cultivation of lepra bacilli, and also resistance studies. Nowadays, resistance has increased in lepra bacilli for the whatever multi-drug therapy that we are giving. So, can we be able to derive economically feasible a cell line like thing for growth of lepra bacilli using stem cell technology?
Stem cells technology to grow?
So that we can with the help of stem cells technology evaluate cells which can help us independently grow lepra bacilli in the laboratory environment, just like we are growing viruses. Do you think it's possible?
Maybe I mean transfection studies would be helpful for that. So that's what I came to know now. But if I have any other info, only transfection studies, I think with the help of transfection studies and other things, we can grow this bacteria.
So till now literature, whatever literature we have reviewed, it's human neural cells, Schwann cells. Those have been used for doing studies regarding metabolism and resistance studies, and also organs like scaffolds they are using for using means metabolic studies were mostly limited
Done.
so that we can get drug targets for it.
Oh, drug targets.
Drug targets. So that
Uh-huh.
was the reason. But never it's not anything which can decentralize diagnosis by having a simple cell line for, because it's still an enigma for many of the clinicians to get a assured reply that yes, it's leprosy. Sure shot leprosy means it's a mimicker, a skin disease which mimics a lot of manifestations and it's very difficult to diagnose. So anything, tissue can be derived and infection can be transfected using an animal armadillo instead of, because maybe I think it's complicated to have a stem cell derived for human and maintaining them, and because it should not be a costly affair again, it should be cost effective.
Yeah.
So it was just a thought that can you think about or help us guide a way so that we can, there is it a possibility or not? So
I have to look into that.
Okay.
Yeah, but it's very interesting. I can look into that. You mentioned an interesting point that we used actually human cells.
yeah.
We used athymic rats.
Okay.
Yeah, so it is little expensive effort, but eventually because mesenchymal stem cells, they are HLA-D are positive, I mean negative, so we can use in any other models also. That way we can make it like cost effective.
Okay.
Yeah, but stem cell therapy, I mean using stem cells, what it comes to my mind is some transfection studies we have to do it, and I think we can manage that. But I'll look into that. It's
Okay.
very interesting to connect the dots.
Yes. So we have many dots to connect here. So I wanted your inputs. Okay, ma'am. Thank you.
Anything from student side or any other?
Madam, I'm an orthopedic surgeon. We have recently got a lot of cases of osteonecrosis.
Uh-huh.
Osteonecrosis.
Oh, osteonecrosis, yeah.
Yeah. So what is the present status of injecting stem cells into the, creating some drill holes into the bone and injecting it
Definitely, sir.
materially?
It is actually my next project. I didn't present that. That is one project we are working on. This is, I want to show this picture. Why we started this. Yeah, actually we got the necrosis. Oh, yeah, I forgot. You see this, the bone, we constructed excellent model, stem cells, scaffold and everything, but it worked when the vasculature, the alveolar cleft model, where the blood vessels are more. When I implanted in subcutaneous model, it did not work because there is no blood supply there. So osteonecrosis is the same thing, avascular region. So that's where we are getting that osteonecrosis. What we have done is, as I said, we differentiated the stem cells into endothelial progenitor cells. Endothelial cells and osteogenic or osteoblasts, they together they implant usually, but what happens is endothelial cells are not proliferative as these stem cells. So we differentiated, we created the endothelial progenitor cells and osteogenic progenitor cells, and we showed that this will enhance the angiogenesis. This is where this osteonecrosis comes. So where the bone is exposed and necrosis bone is happening, then we can use the stem cell therapy. We can excise that part and we can use the stem cell stem cell based bioengineered bone. Definitely we have the solution for that. That's what my next project, what I'm doing now is that focusing on osteonecrosis.
So the real problem is bring the blood supply to that part
Correct,
first.
correct.
Next step is to implant this.
Implant this,
Reason
yeah.
rate.
Yeah.
So we have to first phase we have to develop a technique to improve the blood supply there. Then give this regenerative material there,
Correct, yeah.
and then we'll be successful.
Exactly. The stem cells, we can guide them to endothelial progenitor cells, and then we can create the blood supply. That's one way. If not, we have to excise that part and put the bone graft with stem cell technology. That
No.
is possible.
In osteonecrosis, we got a fibral head, like
Oh.
a ball.
Okay, yeah.
So make drill holes. What we are doing now.
Uh-huh.
But we have no material to put there, which will induce osteoblast there. And already, as you said it, the blood supply is less. Therefore, regeneration is slow. And this is all at the experimental stage only.
Yeah.
We are waiting for a good news from the rest of the world.
I know.
What?
As I declared, it's all like preclinical, and even if we want to go for clinical studies, it's as you know, a lot of documentation and other things. But we are focusing our research on this aspect.
Can we get the stem cells from the bone marrow?
Of course.
Inject directly into those holes.
Yeah, that is one possibility. Hematopoietic stem cells are there. There is a possibility of doing that. Bone marrow. Most of the cases in knee replacement, that's what they do.
Okay.
Bone marrow transplantation, because they have macrophages, that's important, and also hematopoietic stem cells and mesenchymal stem cells. There is a possibility. But what we are trying to do is any other tissue. As I said, this gingiva tissue has the capacity, and even the bone coming from other part is not coming from the neural crest. Only the alveolar bone has neural crest origin, which is appropriate for craniofacial regeneration. So we are using the gingival stem cells. That's the main reason. It is coming from the cranial region only, so it has appropriate stem cells. And utilizing bone marrow is one option, as you know that it's expensive, first of all, and also invasive technique. We are focusing more on non-invasive technique. That is one reason I'm focusing on differentiating this into endothelial, so a lot of vascularization will happen there. And we did see that actually, but we still have to do more studies on that. Yeah.
Thank you. Thank you, madam.
Yeah.
Ma'am, in your study you have mentioned that you will be using the BMPs like the 2 and 7. So is there any specific reason only to use those BMPs like 2 and 7? Why can't we use the other BMPs also, like the 4 or 6?
That's a very good question. Actually, why I'm focusing on BMP2, it is FDA approved material. And BMP2 and collagen sponge, as I said, that infused bone graft, it is also FDA approved only for spinal injuries. We tried that bone graft for like pediatric patients, but FDA did not approve. As you know, BMP2 is endogenously produced, and they were asking if you are putting BMP2 exogenously, it's a problem, and a lot of immune resistance and other things. A lot of questions have come. But that is why I thought that BMP2 is good material, I mean good growth factor, but how can we reduce the quantity? So, that's one of the reasons.
Okay,
BMP, yeah. Other BMP2s are, other BMP are there, BMP7 and BMP9. They're also very good material for bone inducing. But FDA approval is done only for this.
Ma'am, if we want to start the stem cell lab here, what are the limitations that we are handling?
No, actually, as we discussed, you need to have biosafety hood and good preservative method. As I said, characterization is important. because they will come back and ask that, okay, how do you demonstrate that these are stem cells, mesenchymal stem cells? So we need to characterize every batch, and you can maintain that. And you need to have minus 80 liquid nitrogen for storage, and other things like flow cytometry you can send out, but it's live cells. So you need to have that facility. I think I'm sure that flow cytometry facility is not a big deal for characterization. And the lab conditions, you can differentiate all these multi-differentiation things. Definitely there is a feasibility. A lot of institutes are doing that stem cell. And one thing I can mention, that whatever we are doing here, gingival stem cells especially, it is coming from neural crust. It is having ectoderm origin also. So there is I mean, I cannot say it's an issue, but there is a possibility that it will grow into ectoderm also. So we need to take care of that. So homogeneity, that's what I wanted to tell you. So homogeneous population, we have to take it. Lot of heterogeneous population will be there. That is where sorting is important, flow sorting. Thank you, one and all. Thank you for listening to me patiently.
Thank you, Dr. Uma Devi, for a wonderful presentation. We know that we are in this end of the world, and we hardly know, like, though we study in different articles and all, but then now we understand how much of work is being done at each and every center. Thank you so much for your wonderful presentation. And now I think with the little hope you have given, that we can also start because ours is just a budding R&D. I think we are still in the baby stage. So thank you so much. And I request Ambedkar sir and Dr. Sudhir sir to please come and hand over a memento to Dr. Uma. good evening. So you all know why you are all here? Huh? We just thought we'll remind you once again like what are all your duties and what are all our duties. Just to remind you, even when the talk was going on, you were all busy with your mobiles, heads down with mobiles open. More than 50% of you were doing that. You're not even ashamed of what people might think about you. We call people from all over. We try to arrange a program for you. We don't know which is going to be useful for you, but you're not bothered. Your aim is only to spend the time with your mobile. More than 50% of you are doing that, and few were very happily lying down with eyes closed. అంటే ఒకప్పుడు సిగ్గుండేది ఇప్పుడు అది కూడా లేదు. That is not right. You have to behave yourselves like postgraduates. ఫ్యాకల్టీ నిద్ర వస్తే పడుకోవడానికి సిగ్గుపడతాం. బలంతంగా ఇదిగో ఈ అమ్మాయి నీ పక్క అమ్మాయి మీ ఇద్దరు చేతిలో మొబైల్సా? Anyway, I think you have to once again remember what are all your duties. How is it that you all should behave like postgraduates so that you will get a good name, your departments will get a good name, your professors and guides will get a good name, and all put together we'll get a good name as an institute. Okay? Right? At least for the time being, because this is not subject. Close your mobiles. Even if the heavens are going to fall, don't worry. We'll take care of all that and concentrate on what we are going to say. Right? లేవండి పడుకున్న వాళ్ళందరూ కొంచెం బ్యాక్ స్ట్రైట్ పెట్టి కూర్చుంటే అంత నిద్ర రాదు. చిన్న చిన్న టెక్నిక్స్ నేర్చుకోవాలి మీరు. ఓకే సరే. So what recently we have done is, though we already have certain SOPs. You all know what are SOPs? Huh? SOPs తెలుసు కదా. So for postgraduate as an institutional policy, we have an SOP. What are the duties of the postgraduate? What a postgraduate should do and how he should behave, he or she should behave, and what are his rights and what are the rules, what are the regulations as per NMC, because we all go as per NMC only. We don't design our own rules, right? But there are certain things called institutional policies which are designed by the management and the administration together, which you all have to follow. Is it clear, all of you? Now, most of the times it is happening quite good. Most of you are following it. But then we found that there are short discrepancies here and there, like certain things like your attendance or logbooks, which is 10% with all of you, and your portfolio books or your duty timings or your duty hours, your night duties, your dress sense, all these things. Okay, so I think Dr. Sridhar Reddy sir, you will discuss. So we have redesigned our SOPs in a more convenient way for you actually, so that it will be easy for you to follow. ఏంటమ్మా భార్గవి ఏమైనా డౌట్ ఉందా? నన్ను అడిగే డైరెక్ట్గా. నథింగ్. దెన్ డోంట్ టాక్ ప్లీజ్. If you have any doubts here, we can discuss at the end. First listen. Okay, so now this is an SOP which is redesigned more conveniently for you all, and more burden on the department but convenient for you all, so that it will be easier. We have included more of the NMC rules and regulations, so that you will come to know once again what are the rules and regulations. Okay, okay, I want everybody to listen carefully, and then at the end we'll discuss each and every point if you think you have some doubts regarding that. Okay, right.
Thank you, madam. So actually all these SOPs are being designed under the guidance of head of the department. Parle. Okay, sir. Under the guidance and this thing of our dean, all the administrators were involved into this thing, and every point we have discussed, rather to say we fought, but to come to a logical conclusion such that the implementation takes place. These SOPs are being sent to your head of the departments, saying it to circulate to the postgraduates. I hope everyone have gone through it. Yeah? Otherwise, you can ask your head of the departments, they will give a copy to you or what also it is, because it is circulated saying it should be to the postgraduates. There are certain guidelines, nearly 14 guidelines what we have done, means 14 subheadings under which we are going to look into these things. I will go as per the guidelines or this thing. It is one is the responsibility of postgraduate residents in terms to clinical responsibility. So when we talk about clinical response, see there are certain things you are already following it, but when we design an SOP, we need to still keep that points because they are the things what we follow it. Like attend daily ward rounds morning and evening. I know your people are already following it. There's no issue for it, but we write it down. Examine assigned patient or whatever the case may be, maintained update case sheets. That's very clear for you. So already people are doing under the guidance of your assistants, associates, SRs or professors. Okay. Document vitals, daily progress notes and treatment changes. Treatment changes, whatever things. So you are doing all that things. But only the thing it is, all these things should be signed. Unless you sign it with your name and registration number, the things doesn't become valid, which the NMC also insists and we also insist on these guidelines. Okay. Ensure timely ordering and follow-up of investigations. So most of the time the postgraduates thinks that I have written the investigations in case sheet, now my duty is finished. I'm sorry, your duty is even to follow whether they have come back, whether they have sent or not. Okay, when there is some lapses from the nursing side, you can escalate the issues to your head of the departments or further up, that's a different issue. But following up, seeing that the patients get all that investigations done or whatever you desire, the things are happening. So at the end of the day, the responsibility lies on you equally. Okay. Perform procedures as per PG level and competencies. Now this PG level and competencies, what procedures, what postgraduates has to level, this we have directly taken from the NMC. So there are certain things we don't need to invent. The wheel is already invented, we need to copy it. So in that thing, first year resident will have more ward duties, foundational training and academics. This is what written in the NMC. Second year postgraduate residents, specialty clinics, procedures, research work and academics. And third year resident, independent case management under assistant sometimes, academics, exam preparations. These are the things. This is a very brief thing. It is not necessary that you are going to, lakir ki fakir ki tarah nahi rehna ki usko pakad ke baithe. You can deviate, but it should be within that premises. Provide emergency and on-call services as scheduled. Ensure informed consent before procedures and documentation. So informed consent, everything, the end of the day might be the consultant, it all falls on your role that you take informed consent, talk with the patient, explain the things. When it is beyond your capacity, call your seniors, your SRs, your assistants, or professor, get the things done. But whether they are completed or not, it all falls under you. Okay. Ensure communication with patient relatives regarding conditions and prognosis. I know sometimes it is very tough to deal with tough patient attenders. In such conditions, please ensure that you involve your seniors or your faculty into that thing. So when whatever the things written here, it doesn't mean hard and fast you have to adhere. You can take the help, but see that the things happen. Okay. Now daily hours, what is your working timings? The working timings is very clearly mentioned by us here. Daily duty hours is 8 AM to 5 PM. Varies by department, that the department again can take an individual choice, but this is a minimum duty hours where 8 to 5, but if your consultant may say today you need to come at 7, please follow it. Might be some reason that I am going to start a surgery today at 7 and 6, please. That is at the discretion of the, you cannot show this SOP and say, sir, dintlo 8 rasunda nenu 8 intinke vasta. Kudradu. That thing doesn't happen. Okay. And PG must stay till the assigned work is completed. So when we say assigned work is completed, if you are in a surgery, sir, 5 ayipayindi sir, you can't drop, no? You have to complete that thing. So assigned work means whether it is a surgery or non-surgical things, you need to stay till your assigned work is completed, whatever thing. For some people, sometimes it may take 6, 7 or this thing. Okay? Assigned work complete cheskoni vellala roju. Like tomorrow you have you have to post some patients for the surgery, you need to work out all the things. What are the time you need to work out? So this is only a preliminary guidelines to say that your duty hours is from 8 to 5 PM. But however, for the postgraduates, this is beyond that thing sometimes. Duty as decided by the HOD. Always the duties rosters are signed by the HODs. Whatever the duties rosters are signed by the HOD, you are compelled to follow the duty roster. What a thing. Post duty PG has to complete his daily duty before leaving the ward. For example, you have your today worked, you have a duty tonight, you do your tonight duty, tomorrow you complete your duty and leave. And documentation standards, this is again a very big issue. This we need to keep in the SOP. Recently, there are some cases where doctors are fined 5,000 rupees, 10,000 rupees by the court. It is not the amount, but it is the court pointing out to us. That is, maintain legible. Your handwriting should be legible, complete and dated time entries in case files with signature, name and registration number. This is mandatory. And most of the time what we see in the case sheets is there might be time but we don't know. There might be date but we don't know which time the PG has attended the case. If I come in the morning and ask, you will just say, sir, nenu ee roju 8 o'clock attended. Perfect. If I ask for the same case after 10 days, definitely not you. Anyone cannot say about it. So timings under the date is mandatory. We are only mandating now time. So this you have to take the place. I hope all these things are not a tough jobs descriptions what we have written. These are practicable job descriptions. Include presenting complaints, history, examination findings, diagnosis, treatment. Electronic medical records to be used when available. Till now we are not getting, we are on the trial process. So once the electronic medical record comes into the place, you are going to use the electronic medical records as by the institutional policy. Ensure confidentiality per NMC ethics guidelines. So no records should be photocopied, photographed, taken out without the permission of the HOD or used in any presentation without the permission of the HOD. Okay, so nothing should be taken out. So it should be completely a confidential information. And another thing is we sometimes see, I don't know how much it is happening here. I'm not individualizing anything. People carry the case sheets to their hostels or homes. That should never be happened. It cannot be gone out of the gate. Out of the gate means not main gate, out of the hospital gate. No case sheet should go. Now academic activities. So we have some mandatory components and academic activities. There should be a mandatory daily bedside clinics. As madam has said that than the job for you, the description is more job for the HODs and the other people. If there should be a bedside clinic, that means we want to make sure that your assistants should come in the bedside and teach you. So we want to say that every department should have bedside clinics mandatory going on. Follow daily rounds and grand rounds whenever as designated by. So sometimes weekly once the grand rounds might be there, or 10 days once, whatever the HOD decides about the grand rounds has to be followed by the postgraduates at any cost. Weekly seminars are mandatory. Monthly journal clubs is also mandatory to have. I know in all your slips it is coming, but now we are keeping some types of standards into it, like mortality meetings as per the institutional policy which is taking place. The case presentations. So this is in a broad term we have described this thing that at least 3 per semester for every postgraduate case. This is written in this way because at least 3, not less than 3. Like if you take big departments like general medicine where there are 36 postgraduates, when I calculate semester as a 6 months and total working days and all that put together, every third day or second day one PG will get, or third day one PG gets a seminar. So if he presents 3, that is 36 postgraduates, 3 into 36 almost going beyond 100 seminars, and we have only 6 months. Okay, that's the reason this cap has been kept. But if you take departments like dermatology, ophthalmology, where only 6 postgraduates, the frequency of seminars can be more per postgraduate. But this is the minimum seminars we are expecting from a postgraduate for every 6 months. That is, they have to at least present 6 seminars. Sorry, 3 seminars. Interdepartmental meeting for important cases has to be conducted regularly and will be conducted. PGs has to present for it. Minimum attendance required not less than 80% in every year. So attendance will be calculated for every academic year, not all put together. Every academic year you need to have 80% of the attendance. Less than 80% of the attendance implies you are not eligible to the exam. This is not said by me, this is said by the university. And in future we are going to only act as a postman. మీ అటెండెన్స్ ఎంత ఉందో ఇక్కడ అంత మేము యూనివర్సిటీకి పంపిస్తాము. మేము పోస్ట్ మ్యాన్. We are not the person to detain you. We have no right for detain you. We will act as a postman. It's the university, let them decide what they want. So it's all, we are leaving it to the university. We are not taking any burden on us. We won't act as a postman. Now logbook maintenance, record all procedures performed and assisted. Everything, whatever you do, daily activities should enter into the logbooks. It's mandatory, the logbook. And record all academic activities attended. And maintain signature from supervisors or faculty under whom you have done that activity or this thing. And submit logbook at the end of every 2 months. Your logbook will be verified by your head of the department and our academic coordinator, Dr. Ramarao Garu. So they will be verifying your logbooks every 2 months. So any incomplete logbook, we will be not be accepting it, and we will take our action. So there is a strict verification of the logbooks. Now coming on to the research requirements, thesis and dissertation. Select topic under faculty guide by 3 to 6 months. I think there are no new first years, but whoever the first years comes is going to apply this thing. So within the 3 to 6 months, your new topic has to be selected, and submit symposium as per NMC and university guidelines to the ethics committee. Get the internal ethics committee clearance and approval before research begins. Don't begin any research activity or anything without any approval of the ethics committee. If you have anything urgency, still you can write a letter to the ethics committee, take their approval, and only begin the research activities. Conduct research responsibly, maintain data accuracy, submit complete thesis at least 6 months before final exam. Now it is applicable to you also. 6 months before the final exam, all your thesis work has to be completed. And review by the guide once in a month of your thesis, and review by the guide HOD and dissertation committee every 4 months. We are going to review your dissertation. Now we are very keen on reviewing your dissertation, not just to bring one printed material and give to us. No, we want to have all the sources of it. From where did you get? For example, you say, I have collected data from these 50 cases. I want the case sheet number. The committee will be asking for the case sheet number, and we will be checking into that case sheets. So we are not interested to have any type of manipulation. Everything we want the sources properly. Without the sources properly, the committee will not going to accept your thesis. We are okay even if your thesis is not submitted in time. You have to wait for 6 more months to write your exams. We are fine with it. But you have to follow these guidelines from now onwards. So every 4th month, we will be having complete checkup from the committee. Publications. Publication every year is in indexed journals are recommended. It's not mandated, but we recommend that you follow, that you do some publications in the indexed journal. Every year one, it will be great, but even at least 1 in 3 years, it will be acceptable. But nothing is good. If you don't do any publications, may not be good. But paper, poster presentation, state or national conference, not less than 1. It is another mandatory thing as led by the NMC. So we want to see that these things are also happening by you. That paper, poster presentation, at least 1. You can do 2, 3, that's fine. Okay. And professional conduct and ethics, follow NMC code of medical ethics, dress code and grooming standards as per institutional policy, maintain a respectful, compassionate attitude towards patients, ensure privacy and confidentiality under all circumstances, avoid conflict of interest and report misconduct. And there are certain mandatory things what we have designed this time into these protocols. Even these things for some people it may not be. For the new postgraduates it will be applying more. That is, BLS, basic life support should be completed in the first 6 months. Why we have designed this thing is BCLS and advanced cardiac life support to be completed in the first 6 months. You can use them in the practice. There is no point in doing all these things for you before going the exam. Then it is only going to be like mama saying that you just produce a certificate for the exam. So we have decided that these procedures for any postgraduate who come up into this institute to do in the first 6 months. So that planning also will be done from our academic coordinator, Dr. Ramarao Garu. Okay. And good clinical governance is also going to be done in first 6 months. And these are mandatory certificates. I hope many of people would have done certain things. If they are not done, we will be arranging these things at the earliest. AP Medical Council Ethics and Etiquity certificate is also there. But this certificate we have not designed the timeline, which is again a mandatory thing for you. The reason behind it is, from the AP Medical Council, the person has to come and do that thing. So whenever he gets time, he will come and do that thing. So we are not in a position to dictate to the AP Medical Council on that thing. So for that, we have not designed a timeline, but whenever they come, we are going to do it. Research methodologies and biostatistics in first 6 months. This is the course which we do here. But there is another course called as BCBR, which you have to complete in your tenure, where there is no exemption from the university or NMC which you are. So actually this is also best to complete within 1 year, but the problem we are facing it is some of the postgraduates come and say that we are not getting the slots. But our recommendation is better to complete at the earliest in the first 1 year, such that the knowledge of this thing will help you in writing your thesis works. So this is about this thing. Now coming on to the leave policies, which is very important for you people might be waiting for the leave policies and this thing. Annual leave as per the NMC it is 20 days and 5 academic leaves, nothing more than that. Huh? Yeah, per year. Yeah, 20 days per year and 5 academic leaves per year is the leaves what we can grant to you. Anything more than that as per the NMC or university will be considered as an absent. And when it falls below 80%, an extension will come, or you will not become eligible for your this thing exam. However, maternal and paternity leave is as per the Indian policy of Indian government. So NMC doesn't lay any policy for maternity leave. This thing we are going to completely abide by the rules laid down by Government of India. However, a person who has availed that leaves will get short of 6 months, so they will not be eligible for the exam. So we are not going to have any policy where the student writes the exam and after does an 6 months of extension. That is not there. So they have to wait, they have to complete that period and then attempt for the exam, because this is what the university says. Okay? And next, all your attendance from now onwards, if you are taking any leave, you should give a prior intimation in adrenaline, all having that app of adrenaline, I know. So you can apply on the adrenaline for the leave. Only in cases of emergencies where you are not in a position, might be you are sick or something, you can apply afterwards. But we expect all the leaves to be done in the adrenaline. Your attendance every month comes to the principal office from your head of the department, but we are not going to accept only that attendance. We are going to look into the attendance which are present in the adrenaline about your in and out time, which we are going to consider that thing. That is going to be monitored very strictly. And next thing it is, most of the students we see, they don't punch days together, whether they are there in the college or we don't know, but HODs are regularizing that. But now the HOD said that they are not going to regularize every attendance. See, ఒక రోజు మర్చిపోయాము, fine, we can regularize. ఒక రోజు late వచ్చాము, excuse, fine. But it's not that, you are not there for 7 days, you are not punching, and you expect your HOD to regularize for no reason. So for any regularization what you are applying in adrenaline has to be written, the reasons to be written concretely. If that reasons are satisfied, we are going to regularize the attendance. Otherwise, that attendance are not going to be regularized. They come under loss of pay, and simultaneously that will add up to your deficit of your attendance for the university. This we are going to monitor very strictly. And another thing what I am going to try to do is from the principal office, that we will try to update your percentage of attendance on monthly basis. We are working on that thing. I will not promise that it will occur in this month, but just every month you are aware what is your percentage of attendance, where you are standing. That we are going to look into it. All leaves must be pre-approved by HOD and administration except emergency leave. If not pre-approved, you can't have 20 days every time, emergency. When you are having an app, please use it. For final year postgraduates, now here is another thing where we have a lot of discrepancy, that each department is taking their own this thing. So we all sat together, we have taken a decision. For final year postgraduates, he can be exempted from night duties 3 months prior to the date of final examination. However, he will continue to attend his regular duties till 15 days prior to his final examination. So that is going to be for the final year students. Actually, as per NMC, no leaves to be granted. NMC has not given any types of exemption, nor the university has given any type of exemption. This is with a very great heart our people have taken and given this exemption to you. Postings, mandatory peripheral postings, DRP, as decided by the government. You are going to have your DRP postings in second year. However, no DRP postings is going to go beyond Srikakulam district. We are not going to entertain any type of postings or letters brought to go to their hometowns and have the postings. That is no more to be done. We are stopping all that type of postings anymore. So this is a very clear information. Even if you're going to get the letter, we are not going to forward from here. We are going to reject it. We are going to keep the things very clearly on you. Okay. The next thing it is, the number of people going to the peripheral postings will be very clearly decided by the principal office. We don't want irrational number. That is, for example, in a department there are, let me say, 9 PGs. Okay. In a department, 5 PGs or 4 PGs going for a posting. What it is going to do is it's going to create deficiency of PGs in the department. But however, we can plan in that 3 PGs go for the postings every time. For 3 months, 3 PGs are not there, that's not a big issue. Okay. So that type of rationalization of the postings will be done, and this all will be from the principal office for the rationalization of the PG postings. So if, for example, if you want, you have some issue in the next 3 months, but you want to go for the posting, please talk to your colleague, drop him, saying you come afterwards and you can take the place. That thing you can avail that thing, that type of exchanges. It's not that thing, my girlfriend is going, so I will also go for the posting. Sorry, that postings will not be allowed. You will go, but we will drop your girlfriend. Okay. So it is clear for this posting. Now there is another thing called as peripheral posting within the allied department or at the discretion. So allied departments inside the college and allied departments, that all postings can be done by a HOD. But there are certain situations where the peripheral postings, HOD can take the decision for sending the PG to any other place for learning special things which are not available in our institute, and the period of posting can be decided by the HOD along with the dean's office. Like for example, I will say, like psychiatry PGs, they go for neuropsychiatry. We don't have here. I can't deny them of that privilege. So they want to go to NIMHANS. That can be done. Like surgery PGs, that he wanted to learn some GJ-stomies or something. I will not allow them. The reason is they are available here. You got it? So which are not available here. And next thing it is, whenever these type of postings you want to learn some special things, we will definitely help you in that thing. But preferably we will be sending to our parent concerned institute where the technique and technology is available. If it is not available there, then we will select the other institute. ఎందుకంటే sometimes these peripheral postings అంటే మా ఇంటి దగ్గర డెలివరీస్ బాగా నేర్పిస్తారని అక్కడ ఇంటి దగ్గర, there's nothing like that. If you have anything specific, yes, we are there to help you out. So we will not deny you to learn new technologies, new techniques. We will not deny you any type of peripheral postings, but all these things will be rationed and controlled. Evaluation assessment. This we are going to maintain very strict evaluation assessment. We have 2 things, formative and summative assessment. Formative assessment, monthly internal assessment, your department is going to conduct to you. That can be whatever thing, MCQs, small slip test, 3-4 questions times, whatever that thing it is, they are going to do every monthly, and they are going to submit the formative assessment to the dean's office, where we are going to maintain the entire data of every student. వస్తే 100కి 0 వచ్చిందా, 100కి 90 వచ్చిందా, absent అయ్యావా, everything we are going to maintain it, and that will decide many other outcomes. Okay. End of term assessment. So the departments can say 6 months or any term, and they can do the term assessment, and normally term assessments are done by the universities now. So first year, second year, they are doing it, no? So that we are going to, as if that we are going to follow it. We are not going to invent the wheel there. And mandatory to attend university assessment. Next we are going to have summative assessment, that is final exam, theory paper, clinical, practical exams. These things are going to happen as per the university papers only. Means వాళ్ళు ఎలా డిజైన్ చేస్తే అలానే ఉంటుంది. 4 papers, whatever the way they design, it will be in that way. Only formative assessment is at the discretion. Viva voice, there will be also regularly conducted and recorded, and thesis assessment mandatory for exam eligibility. And this thesis assessment, we don't want your thesis to go there and get rejected. If at all get rejected, let it reject here itself. ఒక బయట ఇంకొక ఎగ్జామినర్ దగ్గర పంపించి జెమ్స్ కాలేజ్ థీరీస్ హారబుల్గా ఉంది రిజెక్ట్ అని పంపించేదానికి ఇక్కడ మనం రిజెక్ట్ చేసుకోవటం బెటర్. And whenever we do that thing, we will give with a sound points why we are doing that activities. Okay, any rejection of this thing, so it will be done here. We are going to use a strict plagiarism software that you all know about it, and we are going to improvise the plagiarism software more strictly, or we are going to get a very good version where it can catch nook and corners of it. I think now it is 20% which is allowed for you. Yeah, and we don't know in the future university may cut down further because 20% is a very high this thing. Safety protocols, follow universal safety. See, whatever the end of the day, the safety of our postgraduates is highly essential for us, either in terms of accidents or medical accidents. We are always keen on the thing. Follow universal precautions, use gloves, masks and PPEs as required and wherever required. Report needle stick injuries immediately and follow PEP protocols. Maintain patient and self-safety during procedures. So we are not going to compromise on any type of safety of you and the patients. Even if you have any new suggestions for any safety procedures, anything, we welcome you and we will discuss and we will implement the safety procedures. See, always the safety procedures people think about us. Government మన కోసం హెల్మెట్ గురించి ఆలోచించి హెల్మెట్ పెట్టాం, మనం ఫాలో అవుతామా? లేదు. ఇక్కడ అదే జరుగుద్దేమో పేషెంట్ దగ్గర. Communication and handover, proper written and verbal handover at shift changes. So most of the time we see the night duty people just go off without handovering. We need a proper verbal and written handover to occur, whatever thing it is. Use SBAR protocol, that is situation, background and assessment recommendations, and ensure the critical ill patients are stabilized before handover. So you cannot live without stabilizing. అలా అయితే మీరు అనొచ్చు, సార్ స్టెబిలైజ్ అవ్వాలంటే సాయంత్రం అవుద్ది సార్, నన్ను సాయంత్రం దాకా ఉండమంటారా అంటారు. హియర్ డోంట్ టేక్ ద టర్మ్ లిటరలీ స్టెబిలైజేషన్. అంటే మీరు ఒక యాక్టివిటీ చేస్తున్నారు, ఒక సిపిఆర్ సమ్ యాక్టివిటీ చేస్తున్నారు, కానీ మీ రిలీవర్ వచ్చాడు, అంత మాత్రాన నువ్వు వదిలేసి వెళ్ళకూడదు కదా. అట్లీస్ట్ యూ హ్యావ్ టు కంప్లీట్ దట్ థింగ్ అండ్ దెన్ హ్యాండ్ ఇట్ ఓవర్, సంథింగ్ లైక్ దట్. యూ కాంట్ జస్ట్ చేంజ్ ద ప్లేస్. కాబట్టి నువ్వు సిపిఆర్ 13 అయింది, 14-15 నువ్వు ప్రెస్ చెయ్యి, నేను వెళ్తున్నా అనటానికి లేదు. సో హియర్ ద థింగ్ ఇట్ ఈస్, whenever you are in such type of critical ill sector, please see that the patient gets stabilized, then you move out of the ward till everything is finished, either the written work in the case sheet or stabilizing the patient. Disciplinary action, non-compliance with SOP may lead to, now the disciplinary action, we are going to be very strict on this thing. You may receive a written memo depending on the gravity, or you may receive a suspension from your duties, or the punishment can go up to reporting to university or NMC in severe cases. So severe cases, you can imagine what can be the severe cases. That is a postgraduate, I should not say that word, gives a sexual offense. Definitely we have to report to NMC, or any type of crime, criminal activity. We are not going to give. Small things we may keep up with the memos. So your disciplinary action may extend to this extent. So this is all the general protocols what you need to follow as a postgraduate. However, we have department specific SOPs which is being written in this, but they are incomplete. The reason behind it is, in the last page it is mentioned that department specific protocols will be designed and circulated to you by the head of the departments, and you are going to follow whatever set by the head of the departments. So are the things clear for you now? Very simple steps and simple things. పెద్ద బండరా ఏం పెట్టట్లేదు మీ తల మీద. Okay, now you can have your questions or anything you want.
Sir, one more thing I just wanted to add is yesterday there was an EC meeting in the university, so they have come out with certain proposals which are almost accepted by the executive council. So now they are going to be very strict about the dissertation. That is one thing they have told. Till now no dissertation is rejected. 1 or 2 corrections they are sending. We are finishing all that and sending back. That is happening. But ippudu they are for the past 5 years lo any similar work unda enti everything they are trying to, because now the R&D has become stronger in university. So now they have appointed a committee exclusively for dissertation. That is one of the resolutions they have made. So they are going to be very strict from now onwards. So be very careful. Let us be very careful. Let us do our work sincerely. Manaki ippadi varaku we never had a problem. So let us continue like that. Let us be more careful, more meticulous in choosing the cases and all. And don't just copy paste. I know it is tough to work besides all the clinical work you are doing, but that's your job now. You have to do it. You all have to do it. Most of the things are going on fine, but then still there are certain problems. Like recently we got a complaint that one of the departments, one postgraduate neglected to give an antibiotic for 3 consecutive days, and there was a complaint from the patient, from the attendant, as well as from the other people around. So this should not happen. Maybe that is not true, we don't know, but that has become a big complaint and we had to intrude into that and it becomes unnecessary. So you do your duties properly, write your name down when you have seen, as sir was mentioning, we have to give our names, whoever has seen the case and all, be more responsible, okay? And regarding the plagiarism and all, we are doing a good work as of now. Everything is below 20% and we have the software with us, so we are trying to help you out as much as possible. But some of you are going out and getting the plagiarism check done, paying some money. Please don't do it. You don't have to, because we are buying for you and it's there in the library. We are giving that person that choice to check your plagiarism. So please go there to the library and utilize the service. Why do you want to pay money outside and go and waste your money? You don't have to do it, right? Did you understand? So that's one thing. And the other things, we just insisted only because we want you to be the best out of all. Did you get the point? Huh? We want you to be the best out of all. We want you to do some productive work, and when you go out, Gems College Pillal Kemi Rado Anpichkodu. One of few of our surgery students have gone to Vijayanagaram Government College for maybe I don't know for what, for some training. I think DRP posting and Kunta. They have gone and they have learnt wonderful work, and they were very sincere. They have done a very good job, and there was lots of praise from all those people over there, and they have they have called and told me that they have done a wonderful job. So this is what we want. We want you all to do your best, get a good name everywhere, so that a college gets a good name. We are insisting on that, that's all, and nothing big. You are all doing your work, but improvise it further so that we won't have all these problems, right? Okay, don't get involved into any controversies. All these things are very important, especially the DRP postings and all. Few areas students are not going at all, and so recently in front of Vice Chancellor, one of the executive members was commenting that these people don't even come there, they don't even work there, about GEMS postgraduates and interns, so which is not good. That's one area, of course, I'm talking about, but there are many other areas where people are going, but then even that area we should not get a bad name. And one executive member commenting on us like that in front of the Vice Chancellor, it doesn't give good look to any one of us. We had to just keep quiet. We could not say anything because we really don't know the truth. You are getting us the attendance and we are believing it. We don't know whether you're buying the attendance or you're really getting it, going there, working and getting. We really don't know all these things. But then please be sincere to yourselves. After all, you're going to get benefited out of all that, right? So take everything very serious. Don't just ignore anything, right? And even Friday CMEs, even today's talk, 50% of you are not there, and you were standing outside, sending a word through the attender whether to come inside. Why like that? This is arranged exclusively for you. I cancelled all the presentations. Because I cancelled the presentations, we wanted to conduct a meeting today only, so that you will not waste your time. Why don't you come? Are you really that busy not to spare at least half an hour for a talk? Lemma, nidrapoku. Huh? Okay. చెప్పి గొంతు పెడుతుంది.
No, we don't want to insist much. See, one thing, an institute becomes better only it has some cultural change and cultural development. And a culture means what type of things you want to set to your juniors who are going to come and join as a postgraduates. And the big institute like CMC's, PGI Chandigarh, they have not become great one fine morning. They have introduced changes, they start worked out. Yes, yes, sir. Imagine if you as a postgraduate in PGI Chandigarh, what is the workload? అక్కడ ఏం కిచ్కిచ్ చేయరు. ఎందుకు చేయరు అక్కడ కిచ్కిచ్? దీనికి డబుల్ వర్క్లోడ్ ఉంటుంది అక్కడ, అసలు ఇంటికి కూడా పంపారు. చెప్తున్నాను అంటే ఇక్కడ ఇంటి అట్లా నేను అనట్లేదు, బట్ యూ డోంట్ టాక్. బట్ డూ యూ ఎక్స్పెక్ట్ దట్ టైప్ ఆఫ్ కల్చర్ టు కమ్ హియర్, దట్ టైప్ ఆఫ్ స్టాండర్డ్స్? Everyone say yes, we want an institute which is like PGI Chandigarh, we want an institute which is like AIMS, we want an institute like CMC. How does that come? It is all comes from you only. So my request is you please keep the cultural change, get the things into place. Okay, so on the last thing, any questions from them? Have anything? Want to ask anything?
And maternity leave, we are going to present the same maternity leave as we have been doing. Every month the attendance is
That's fine. లేదు అంతే 80% that's mandatory now from we are decided. అది కూడా యూనివర్సిటీయే చెప్పింది, 2 మాటలు యూనివర్సిటీయే చెప్పింది. ఏం లేదు అంటే ఐ హోప్ యూ పీపుల్ హ్యావ్ ఫైన్ విత్ ఆటో SOPs and you are going to follow what are the SOPs written here. పర్లేదు మేడం, నిద్రలోనే కన్సెంట్ తీసేసుకున్నాం, పేషెంట్లు కూడా అలానే తీసుకుంటారు కదా. అయిపోయింది, వీళ్ళ దగ్గర కన్సెంట్ తీసేసుకున్నాం. ఏ బా యూజీలు మాట్లాడరు, పీజీలు మాట్లాడరు. లేదు ఓకే మేడం, అదే వాళ్ళ గ్రేట్నెస్.
శంకరంలో పోస్తే ఏం తీర్థం కాదండి, నేనేం చెప్తాను. ఇంకా ఆంధ్రప్రదేశ్ ప్రభుత్వం అందరికీ పథకాలని పంచిపెడుతుంది. మీరు కూడా ఇది ఒక పథకం కింద అనుకోండి. ఫస్ట్ పథకంలో ఏంటంటే మీ సంక్షేమ పథకం అంతాను, మీ సంక్షేమమే మా ఇన్స్టిట్యూషన్ సంక్షేమం. ఫస్ట్ పాయింట్ తొందరగా వెల్ఫేర్, యువర్ వెల్ఫేర్ ఈజ్ అవర్ వెల్ఫేర్. సో ఫస్ట్ తొందరగా నిద్రపోండి, తొందరగా లేవండి, టైంకి వచ్చేయండి, 8 గంటలకల్లా రిపోర్ట్ చేయండి. దట్ సేవ్స్ యువర్ హెల్త్, మీ హెల్త్ని రక్షించుకోండి. దట్ ఈజ్ నెంబర్ 1. నెంబర్ 2, కేస్ షీట్ పేషెంట్ కోసం రాయట్లేదు, కేస్ షీట్ మీకోసం రాస్తున్నారు అనుకోండి. కేస్ షీట్ రాసేటప్పుడే న్యూ ఐడియాస్ వస్తాయి. యాక్షన్ ప్లాన్, డిఫరెన్షియల్ డయాగ్నోసిస్ని డిజైన్ చేయడంలోనే ఎప్పుడు మీ యొక్క నాలెడ్జ్ని, మీ యొక్క తెలివిని వాడతారో అప్పుడు దెన్ యూ విల్ రిఫైనింగ్ యువర్ నాలెడ్జ్. మీరు అందరూ కేస్ షీట్ పేషెంట్ల కోసం, హాస్పిటల్ కోసం రాస్తున్నారు అనుకుంటారు, అదే తప్పు. కేస్ షీట్లు మనం కరెక్ట్గా రాస్తే అది మన నాలెడ్జ్ని ఇంప్రూవ్ చేస్తుంది. దట్స్ హౌ ది జనరేషన్స్ ఆఫ్ స్టూడెంట్స్ హ్యావ్ లర్న్డ్, అండ్ అన్ఫార్చునేట్లీ దిస్ కల్చర్ ఈజ్ స్లోలీ గోయింగ్ అవే. సో ఐ టెల్ యూ, మీరు అది అలా కేస్ షీట్లన్నీ అలా కరెక్ట్గా రాసిందే రాస్తూ అలా రాస్తూ ఉంటే అట్ ది ఎండ్ ఆఫ్ ది టర్మ్, అట్ ది ఎండ్ ఆఫ్ ఫైనల్ ఇయర్ ఎగ్జామ్లో మీరు చాలా ఫ్లూయెంట్గా మాట్లాడతారు. ఆ ఫ్లూయెన్సీని చూసే ఎగ్జామినర్స్ ఇంప్రెస్ అయిపోతారు. దట్స్ హౌ యూ హ్యావ్ టు క్రాక్ యువర్ ఫైనల్ ఇయర్ ఎగ్జామ్. వాళ్ళందరూ ఎప్పుడు మీరు ఎగ్జామినేషన్లో గ్యాప్స్తో గడబిడవుతూ బ్రెయిన్ చేస్తారో దట్ ఇండికేట్స్ దట్ యూ హ్యావ్ నాట్ వర్క్డ్ వెల్ ఇన్ ది 1 minute is enough for the external examiner to assess you, not 3 ఉదయం సాయంత్రం వరకు కూడా. వాళ్ళు వెంటనే చెప్తారు దిస్ క్యాండిడేట్ ఈజ్ ఫిట్, దిస్ క్యాండిడేట్ ఈజ్ అన్ఫిట్ అని వాళ్ళు చెప్పగలరు. సో కేస్ షీట్లు రాస్తే యూ విల్ బికమ్ కంఫర్టబుల్ ఇన్ ది ఎగ్జామినేషన్స్, యూనివర్సిటీ ఎగ్జామ్స్. దట్ ఫస్ట్ అది చేయండి. డాక్యుమెంటేషన్ ఇంప్రూవ్మెంట్ చేయడంలో యూ విల్ బి బెనిఫిటెడ్. అండ్ సెకండ్ అండ్ థర్డ్ పాయింట్ ఏంటంటే అకాడమిక్స్ మీరు ప్యారలల్గా చదవడం నేర్చుకోండి. వన్ కేస్ యూ హ్యావ్, సపోజ్ ఎనీ డిపార్ట్మెంట్ విల్ హ్యావ్, ఏ సబ్జెక్ట్ అయినా ఒక 100 టైప్స్ ఆఫ్ కేసెస్ ఉన్నా మనం 20 or 30 కేసెస్నే మనం క్లినికల్ సైడ్లో చూస్తాం. మనం ఎప్పుడు వార్డ్లో కానీ లేకపోతే రొటీన్ ప్రాక్టీస్లో కానీ వాటినే మీరు అది చదువుతూ రిపీటెడ్గా చదువుతూ ఆ కేసు వచ్చినప్పుడల్లా ఆ టాపిక్ చదువుతుండే. ఆ కేసు వచ్చినప్పుడల్లా మీరు దాన్ని మళ్ళీ ఏదైనా ఇంకా కొత్త, ఈవేళ హ్యారిసన్ చదివారు లేకపోతే ఇంకేదో బెయిలెండ్లో చదివారు, నెక్స్ట్ టైం అదే కేసు వచ్చినప్పుడు ఇంకో పుస్తకం చదవండి. చదివితే దెన్ యూ విల్ ఇంప్రూవైజ్ యువర్ నాలెడ్జ్ ఇన్ దట్ పర్టికులర్ కేస్. ఆ కామన్ కేసెసే మీకు డిస్కషన్ ఉంటుంది ఎగ్జామ్లో ఎప్పుడైనా సరే. ఫైనల్ ఎగ్జామ్లో అదే డిస్కషన్. సో రిపీటెడ్గా ప్యారలల్గా చదవడం, కేసు ఉన్నప్పుడు ఆ కేసు గురించి ఏ రోజు తర్వాత చదవడం, అదొక హ్యాబిట్ చేసుకోండి. చేసుకుంటే యువర్ అకాడమిక్స్ విల్ బికమ్ గ్రేట్. ఐమ్ టెలింగ్ యూ. రిమైనింగ్ ఎగ్జామ్ కోసం చదివేది ఒక 50% బుక్ అంతా చదివి పుస్తకంలో అదే పరీక్షలో వామిట్ చేయడానికి చదువుతాం మనం. అదంతా మీరు ఎలాగా పీరియాడికల్గా ఇక చదువుకుంటుంటారు. ఏదో ఫిక్సెడ్ అవర్స్ డైలీ చదవడానికి కేటాయించి మీరు చూసే రొటీన్ కేసులు రిపీటెడ్గా చదవండి. నేను ఈవేళ ఇది ఫలానా పెప్టిక్ అల్సర్ చదివేశాను ఇంకా అయిపోయింది ఫర్ ఎవర్ అనుకోకండి. ఈవేళ ఒక పుస్తకంలో పెప్టిక్ అల్సర్ చదువుతారు, నెక్స్ట్ కేసు మళ్ళీ అది వచ్చినప్పుడు ఇంకో పుస్తకంలో చదవండి, మోనోగ్రాఫ్స్ తీసుకోండి. అట్లా చదివితే యువర్ నాలెడ్జ్ బికమ్ మోర్ వాల్యూడ్. దిస్ ఈజ్ హౌ యూ హ్యావ్ టు ఫినిష్ యువర్ ట్రైనింగ్. అంతే. ఇంతసేపు వీళ్ళందరూ ఇన్ని రూల్స్ ఇన్ని చెప్పారు మీకు. వీటన్నిటికీ జిస్ట్ ఆఫ్ దిస్ ఈస్ దిస్ 3 things. ఫస్ట్ కీప్ అప్ యువర్ హెల్త్ సో దట్ యూ విల్ ఒక అడిక్వేట్ అమౌంట్ ఆఫ్ స్లీప్ ఉండాలి ప్రతి దగ్గర, ప్రతి వాళ్ళకి కూడా. అడిక్వేట్ అమౌంట్ ఆఫ్ స్లీప్ని సాక్రిఫైస్ చేయకండి. బికాజ్ యు ఆర్ ఆల్వేస్ అటాచ్డ్ టు ది స్క్రీన్స్. కాబట్టి యూ అడిక్వేట్ అమౌంట్ ఆఫ్ స్లీప్ ఇచ్చినట్టయితే యూ విల్ గెటప్ ఎర్లీ అండ్ యూ విల్ కమ్ టు ది టైమ్ టు ది వార్డ్ ఇన్ టైమ్. దానివల్ల మీకు ఏమవుతుందంటే ఏదైనా వెన్ ఏ డే బిగిన్స్ ఇన్ రైట్ టైం ఎవ్రీథింగ్ గోస్ రైట్ ఇన్ ది డే. వెన్ ది డే బిగిన్స్ ఎట్ ద రాంగ్ టైం everything goes wrong in the day. That is a universal rule. Not only in your postgraduate, in anybody. జీవితంలో ఏదైనా సరే అంతే. అందుకు లెట్ us మేక్ అవర్ బిగినింగ్ రైట్. అది చేస్తే మీకు అడిక్వేట్ స్లీప్, అడిక్వేట్ వర్క్, కంఫర్టబిలిటీ వస్తుంది. ప్రాపర్ డాక్యుమెంటేషన్ విల్ ఎన్హాన్స్ యువర్ క్లినికల్ స్కిల్స్ అండ్ ఎబిలిటీ టు ఫేస్ ది ఎక్స్టర్నల్ ఎగ్జామినర్స్ ఇన్ ది ఫైనల్ ఎగ్జామినేషన్. అండ్ రీడింగ్ టెక్నిక్ ఈజ్ టు read parallelly along with the case. Case ఎప్పుడు ఉంటే ఆ కేసుని చదవాలి. That's all. This is in 3 simple points. If you follow this without anybody's help, చూసారా తలెత్తుకొని మీరు పాస్ అయిపోవచ్చు. అర్థమైందా?
And ఇప్పటి వరకు externals when they come to upload the marks, very rarely they'll be happy. ప్రైవేట్ కాలేజ్ ఇలాగే ఉంటుంది అంటున్నారు. నిజంగా అంత బ్యాడా? మన టీచర్స్ మన దగ్గర మెటీరియల్, వీ హ్యావ్ లాట్స్ ఆఫ్ మెటీరియల్, యూ హ్యావ్ లాట్స్ ఆఫ్ స్కోప్ టు లెర్న్, బట్ దెన్ యువర్ పర్ఫార్మెన్స్ షుడ్ బీ ఈక్వలీ గుడ్. ఓకే, సో ఇప్పటివరకు మన అంత బాగా ప్రేస్ చేసిన ఎగ్జామినర్స్ నేను చూడలేదు. అండ్ వీ రియలీ వీ ఫీల్ లో ఆ టైంలో, బికాస్ ఐ విల్ బీ దేర్ ఫర్ ఎవ్రీ మార్క్ ఎంట్రీ, రైట్? ఉంటాను, ఐ హ్యావ్ టు సైన్ ఎట్ ది ఎండ్, ఏదో దయతో పాస్ చేస్తామన్న ఫీల్ ఇస్తారు వాళ్ళందరూ. సో వాళ్ళందరినీ భాస్కర్ సార్ ఎప్పుడు చెప్తారు కదా, ద రిలేషన్ బిట్వీన్ అ స్టూడెంట్ అండ్ టీచర్ షుడ్ బి ఛాలెంజింగ్ అని. అలా మీరు ఛాలెంజింగ్గా ఉండాలి. యూ ఆర్ క్యాపబుల్, నాట్ దట్ యు ఆర్ నాట్. బట్ సమ్హౌ మీరు ఇప్పుడు కూడా చూడండి, ఏమైనా అడగాలి అంటే యు ఆర్ నాట్ ఓపెనింగ్ యువర్ మౌత్. దెర్ ఇస్ నో కమ్యూనికేషన్ ఎట్ ఆల్. మీరు మాతోటే మాట్లాడరు. మామూలుగా బయట బాగుంటారు, అందరితో బాగా మాట్లాడతారు, చెవుల్లో మాట్లాడుకుంటారు, బట్ యూ డోంట్ స్పీక్ టు అస్. సేమ్ థింగ్ హ్యాపెన్స్ ఈవెన్ ఇన్ ద ఎగ్జామ్ ఆర్ భాస్కర్ సార్ మాట్లాడినప్పుడు యూ డోంట్ టాక్. That doesn't really give a good look. Why, I don't know. Not just you, even the undergraduates are equally bad. But they are picking up now. At least the coming batches, we are insisting on communication skills and they are picking up very well. But meer alage undipoyaru. Speak out something. If you are wrong also, no problem kada. When I ask you, okay na ante okay అని కూడా చెప్పలేకపోతున్నారు మీరు. What is wrong? And you feel that మీరు ఆన్సర్ చెప్పడానికి మేము తగవా ఏంటి? సరిపోవా మేము? ఇంకా పెద్దవాళ్ళకే చెప్తారా మీరు ఆన్సర్స్? అదేం కాదు కదా, మాట్లాడండి, మాతో మాట్లాడచ్చు. అండ్ వన్ మోర్ థింగ్ ఇస్ వీ ఆర్ నౌ ట్రైంగ్ టు గెట్ ద ఫీడ్బ్యాక్ అబౌట్ ఈచ్ అండ్ ఎవ్రీ పోస్ట్ గ్రాడ్యుయేట్. we have started getting feedback about each and every postgraduate. Now we know who is really sincere, who is working, who has really absconded from giving the antibiotics. Anni information maaku vachindi, vastunnadi. This is required not just for to improve your performance, but for NAC purpose. వీటన్నిటికీ రాయల్ కాలేజ్ ఆఫ్ సర్జన్స్కి వీటన్నిటికీ మేము ఫీడ్బ్యాక్ ఇవ్వాలి అంటే we need to have so many different sources of taking feedback. This is one of the sources. Then only we came to know that, I don't say everybody, but definitely 87 batch, 87 మీ బ్యాచ్ 84 ఉన్నారు. 84లో మోర్ దెన్ 10 పీపుల్ ఉన్నారు అలా ఎగ్గొడుతూ వేరే వాళ్ళ మీద తోసేసి అసలు కాన్షియన్స్ అన్నది లేకుండా పేషెంట్ చస్తే చచ్చాడు అని తిరిగిన వాళ్ళు ఉన్నారు. ఒక 10 పీపుల్ మేము ఐడెంటిఫై చేసాం. దట్ ఈస్ నాట్ గుడ్. మీకే తెలుసు, మీ అందరికీ తెలుసు ఎవరేంటో. సో కొంచెం కేర్ఫుల్గా ఉండండి. ఐ థింక్ కమింగ్ డేస్లో వీఆర్ గోయింగ్ టు టేక్ సీరియస్ యాక్షన్. పేషెంట్ కేరే కదా మనకి ప్రైమరీ ఇక్కడ డ్యూటీ, ప్రైమరీ రెస్పాన్సిబిలిటీస్ పేషెంట్ కేర్. అది చేయకపోతే మాత్రం మేము క్షమించాం. చదవకపోయినా క్షమిస్తాం, ఇంకేం చేయకపోయినా క్షమిస్తాం. CMEకి రాకపోయినా క్షమిస్తున్నాం కదా. ఎనీథింగ్ వీ విల్ డూ. బట్ పేషెంట్ కేర్ దగ్గర కాంప్రమైజ్ అవుతున్నారు అని మాకు ఆల్రెడీ వచ్చింది. వీఆర్ కీపింగ్ ఎన్ ఐ ఆన్ సచ్ పీపుల్. వీఆర్ నాట్ గోయింగ్ టు కీప్ క్వైట్. డోంట్ థింక్ వీఆర్ జస్ట్ కీపింగ్ క్వైట్. వీఆర్ వెయిటింగ్ ఫర్ ద రైట్ టైం. సో ప్లీజ్ టేక్ ఇట్ వెరీ సీరియస్ ఆల్ ఆఫ్ యూ. ఇంటెన్షనలీ చేయకపోయినా అన్ఇంటెన్షనల్గా కూడా పేషెంట్ కేర్లో కాంప్రమైజ్ అవ్వకండి. దట్ ఈస్ వెరీ ఇంపార్టెంట్. ఓకేనా? రైట్. అండ్ ఆర్ ప్రైమరీ డ్యూటీ అదే కదా. మరి ఫస్ట్ ఇయర్లో జాయిన్ అయినప్పుడు మీరేం చెప్పారు? సొసైటీ సేవ చేసేస్తాం, కార్డియాలజిస్ట్లు అయిపోతాం, అందరూ చెప్పే కామన్ మాట. ప్రజలకు సేవ చేస్తాం. ఇదంతా ప్రజలకు కాకపోయినా మీ దగ్గరికి వచ్చిన వాళ్ళకైనా మీరు సరిగ్గా సేవ చేయాలి. రైట్? దట్స్ ఫైన్. బాబోయ్ దేవుడా, వెనకాల కామెంట్స్ బాగానే చేస్తావు కదరా నువ్వు, స్పెక్స్ అబ్బాయి. యూ కమెంట్ బిహైండ్ వెరీ వెల్, బట్ నౌ యూ ఆర్ నాట్ ఓపెనింగ్ యువర్ మౌత్. Okay, fine. That's it. Anything else, sir? Okay, anyway, thank you all. Try to understand our intention. Our intention is to bring out the best postgraduates from the college by all means, academically, skillfully, everything by all means. అంతకు మించి మా ఇంటెన్షన్ అదే తప్పించి మిమ్మల్ని ఏదో పాయింట్అవుట్ చేయాలని అయితే మాత్రం కాదు. బట్ దాంట్లో ఏం తేడాలు వచ్చినా మాత్రం ఊరుకోం. అంతవరకు యూ హ్యావ్ టు అండర్స్టాండ్. రైట్? ఓకే, ఫైన్. హ్యావ్ గ్రేట్ డే. బాయ్.